till the sun begins to sink under the weight of all of us. And as the fire burned, we saw reflections of the flames in each of us.
All right, moving on to adrenal gland diseases, we're going to talk about hyperadrenocorticism and hypoadrenocorticism. And both of these diseases we'll talk about in their relationship to the hormones that allow the body to work through stress. So those hormones that allow the body to fight or flight or fight or flee, however you want to say it. And specifically cortisol. So cortisol is signaled for release from the pituitary gland during any stressful body event, and then the adrenal gland releases cortisol to increase the body's ability to metabolize glucose and to maintain blood pressure and essentially to adapt to a stressful environment. So keep that in mind when we start talking about cortisol and its role in either of these diseases. So adrenal gland are the little glands. They sit on either side of the kidney, one on each kidney at the cranial aspect. They're quite small. And again, they're regulated by the pituitary gland. So they receive signals from the pituitary gland that tells them what to do. So it tells them to release hormones in certain levels. It's that continuous feedback loop. So the cortex secretes 3 different types of hormones, which are affected by the adrenocorticotropic hormone, so ACTH, and this is secreted by the pituitary. So the pituitary secretes ACTH, and then that tells the adrenal glands which hormones it needs to produce in order to adapt to a stressful situation. The medulla operates on the sympathetic nervous system. So there are a few adrenocorticotropic hormones. We've got aldosterone, which is a stress coping hormone. The one that we're really going to focus on is cortisol, so hydrocortisone, and that is to increase blood glucose levels during times of stress to allow the body to metabolize more glucose. It also plays a really big role on blood pressure, like I mentioned, and overall the body's general ability to cope with physiological stress. So increase the use of protein and fat for energy when we have cortisol floating around in the system, increase glucose production in the liver cells, and then it's controlled by ACTH, like I was saying. So the increase the use of protein and fat for energy and increase in glucose production in the liver cells, again, that is in a fight or flight situation. We need the body to react, we need more glucose, we need it to be metabolized, so that's what cortisol is regulating and allowing the body to do. So we'll talk about Cushing's disease first. This is hyperadrenocorticism. And essentially, Cushing's disease is an overproduction of cortisol. Oops. So clinical signs, animals often gain weight and they get a pendulous abdomen. They often lose their hair. They get increased pigmentation in their skin. They get PUPD. Upon CBC, they will have a stress leukogram visible, so they will have an increase in neutrophils, decrease in lymphocytes. They often have lipemic serum. They have hyperglycemia because that cortisol is interacting with the liver to create more blood glucose to be circulated through the blood, and they also have an increase in cholesterol. So these guys, I always have this clinical picture of a little poodle that an owner carries in, and the poodle's pretty happy, but the poodle looks like crap. So the poodle is happy, it's wagging its tail, it's got lots of energy, that's no problem. But the poodle's got, its hair is missing, it's got a really thin coat, you can see its skin, you can see its pigmented skin, so their skin starts to turn like a dark brown or a black. And then they get this potty, pendulous abdomen. And then also common with Cushing's is they get a rat tail, which is really unfortunate. So they get loss of hair around their base of their tail and throughout to the tip of their tail as well. So picture poodles. I always picture a little white dog being carried in because that's how people treat little white dogs. And then you look at this poor dog. It's happy, but its skin looks like crud. Its belly is big. It's got a little rat tail. And for me, that's like your quintessential Cushing's dog. They do feel good. That's one thing that's kind of nice about Cushing's. It's not like Addisons that we'll talk about. Addisons has really big implications on the body. Cushing's does too, especially with high levels of glucose in the blood for long periods of time. But overall, they are getting a lot of hormones that allow their body to deal with stressful situations. So at least anytime they're stressed, their body's not just falling apart, like we'll see with Addisons. And I don't know if you can hear this, but there's a pug snoring in the background, so I hope it doesn't interfere too much with the recording. Okay, so those are the general clinical signs, and if we go back and review them just a little bit, they can be indicative of other diseases. Like we talked about diabetes, we can see PUPD with diabetes, the hair loss and that increase in pigmentation, we can see that with hypothyroidism as well. So just be aware they do overlap until we start to look at the clinical chemistries and the blood analysis. 30% of dogs who have Cushing's only show PUPD, so polyuria, polydipsia. Okay, so they can be happy, totally normal looking, essentially wouldn't even notice it, except that their owner might maybe mention that they seem to be drinking a little bit more, or when they pee, it seems to be a lot of urine. So Cushing's is caused by two general causes, or there are two general causes of Cushing's. We've got pituitary-dependent hyperadrenocorticism, so that's PDH, and this is all reliant on the pituitary gland. It's the most common, happens in 85% of Cushing's cases, most often middle-aged to older animals, and it's small to medium. Now, I talk about dogs a lot with Cushing's disease, but it's important to note as well that horses get Cushing's disease quite often too. So similar signs and symptoms, varies a little bit here and there, but the clinical analysis is quite similar as well, or the laboratory analysis. So the second type is functional adrenal tumor. So this means that their adrenal gland is working, but there's neoplasia that is affecting it to a point as well. So this is neoplasia. It's less common, and it often is in large breed dogs. So we're going to talk about Cushing's disease and how to get to a diagnosis of Cushing's disease, which isn't our role, that's the doctor's role. But we're the ones taking the blood, we're sending the blood work off, we're running it in-house, etc., etc. So getting a diagnosis of suspected Cushing's is one thing, and then getting a full diagnosis of what type of Cushing's it is a completely different ballgame. And we start to get down this winding yellow brick road, this path that never really ends, trying to get to a diagnosis. So just keep in mind when we start talking about getting into the testing here, we have to remember that there definitely is a cost for the owners, and we should really outline the end goal when we're talking to them about going down this road for testing. So the first test we often run is that ACTH stimulation test. So we should be able to give them a synthetic ACTH. So the synthetic ACTH material, give it intravenously, and with that, their body should increase their cortisol production, because naturally in the body, when ACTH comes down from the pituitary gland, that stimulates the adrenal glands to produce more cortisol. So when we give a synthetic ACTH, the thought is that it will increase cortisol production. So what would happen, we would take a resting cortisol level and see what it is, if it's normal, if it's high, and then ACTH will see a significant increase in cortisol level. We'll compare this to Addisons in a few minutes, because Addisons we also start with an ACTH test and we don't see an increase in cortisol. So with this one, it's great, and it starts to identify the path that it could be Cushing's disease or hyperadrenocorticism, but it doesn't tell us the difference if it is PDH or the neoplasia. So if it's that pituitary dependent or if it's the functional adrenal tumor. In this case, though, we can rule out Addisons. So like I said, Addisons we won't see any increase in cortisol production, so we can rule out Addisons in this type of case with the ACTH. Secondary, we might run a low-dose dexamethasone suppression test. A normal gland should suppress the dexamethasone. In Cushing's disease, there's no suppression of dexamethasone resistance. And I have to fix this, but there's a spelling error right there. Just ignore that for now. So that again clarifies that, yep, it looks like we are looking at hyperadrenocorticism for these animals. If the ACTH showed no cortisol increase and the low dose dexamethasone suppression test had no suppression or it had dexamethasone resistance, then yeah, that's heading towards Cushing's. Another one we can run, urine cortisol creatinine ratio. Greater than 0.5 is likely Cushing's, but again, it's none of these tests are distinguishing between the pituitary dependent type or the adrenal tumor. And then lastly, truly the gold standard. So once we get to the point, once the doctor's gotten to the point where they've identified that yes, this is very likely Cushing's disease, this is very likely hyperadrenocorticism, and they want to find out if it is neoplasia or if it's a pituitary dependent, then the gold standard is the adrenal gland ultrasound. So this is the gold standard to differentiate between the two. Really important to note that there are costs involved in this. So like I said before we start going down that path of Cushing's diagnoses, and the doctor's going down this path, we're just supporting it in a way. It's really important, I think, to give the client an overall estimate. So what is their end stage medication cost? What's their end stage diagnosis cost? Because that way it gives them a better idea. They feel a little more empowered. They don't feel like they're just being swindled to try to go down this path to find an answer for the test or for the disease that's affecting their dog. So we can help with that, and we can encourage veterinarians to help with that and sort of create an estimate of how long are they going to be testing to try to find out what this is and how much is that going to cost them. It is, in the end, very important to differentiate between the two, the neoplasia versus the pituitary dependent, because if it's pituitary dependent, it's going to be receptive, it's going to be, it'll change, with medications, so that will be really good. If it's neoplasia, then that's a different path that the owners have to take, and it has to be treated more as a neoplasia rather than primary Cushing's disease. So treatment on this one, I'll post the link if you're just watching this on YouTube. If you have the PowerPoint notes, then you can click on this little purple treatment down at the bottom, and it is a hyperlink. So it's a good article. I think it was from a conference. I found it on the Veterinary Information Network, and it has a whole bunch of treatment options for Cushing's. So again, this is one that the clients often feel like, they kind of feel like they're being strung along when they're getting all the testing done, because the testing is so immense. It's quite a path to get to a finalized answer about what is causing the Cushing's specifically. And then when we start looking at medications, it's kind of the same thing. So it's a huge path, lots of options in regard to medication, but sometimes it's trial and error to see what the body will respond to. So again, us as the RVT prepping the client for this is really important. The good news is that the dogs, and whoever else it is, but the dogs they typically feel pretty good with Cushing's. They typically, they might not look so hot in regard to their skin and their hair, and they're drinking more and urinating more, but a lot of them that don't have clinical signs, they're feeling pretty good because cortisol is allowing their body to respond to physiological stress. So that's a way that I am able to cope with clients who aren't able to go down the path of diagnosis and treatment sometimes. It's just something to think about. Okay, Addison's disease is the opposite. So Addison's animals are hypoadrenocorticism, so they have no cortisol production or a minuscule amount of cortisol production. So what that means is when the body says, hey, it's stressful, hurry up, start helping the body out, help cope with stress, we gotta stand here and fight, or we gotta run away. Normally what happens is we get a surge in cortisol, we get an increase in blood pressure, the body responds appropriately, increase in heart rate, increase in metabolism, go, go, go. And instead, in hypoadrenocorticism, their cortisol is nothing. So they have no cortisol. So their brain, pituitary gland, is like, hey, let's go. I'm releasing ACTH. It's a stress situation. We need to get the body ready to go. We got to fight or flight. And in their case, sadly, they just fall apart sometimes. And that's how they end up in an Addisonian crisis that we'll talk about. So it's a stressful situation, and the body physiologically can't cope, and it physically can't cope with it. That is Addison's to a T. So clinical signs of Addison's, my lord, there are so many of them. So it could be PU, PD, it could be vomiting, it could be diarrhea, it could be lameness, it could be muscle tremors, it could be, I don't know, the dog spinning in circles. There are so many ridiculous symptoms of Addison's because their cortisol and that stress effect is starting to change their electrolyte balance. It's starting to change their sodium potassium ratios. It's changing some of their other clinical chemistry values. There are so many areas of the body that sort of stop functioning at an ideal level. So, clinical signs of Addison's, anything could be a clinical sign of Addison's. And this is the hardest part because Addison's often affects female dogs. When we're talking about dogs, it often affects females that are young to middle aged. So, like 2 to 6 years old is typical age for Addison's. Sometimes you see a bit older. I've seen 9 years old recently, but 2 to 6 years old is pretty common, female more often than not. And when the doctor sees it for the first time and they've never experienced an Addisonian crisis before, a lot of people are at a loss because until they do that blood work, those clinical signs they just look like anything else. They could look like any other symptom in the book for any other disease. My example was my dog Leia, that I'll talk about a lot in this PowerPoint. So her Addisonian issue, I didn't know she had Addison's at the time. We adopted her when she was 2.5, and I think it was within a year. So that first year, she always had diarrhea. So we thought, oh my God, okay, is it Giardia? No, it wasn't Giardia. Is it exocrine pancreatic insufficiency? No, it wasn't that. So we did a bulk of tests to rule that out. And then mysteriously, the diarrhea went away. And then every so often, she would barf. And barfing is the clinical term for throwing up, right? Right? It's totally appropriate. So she'd throw up periodically, just randomly, and then she would randomly become lame on one limb, and the next week it would be the next limb. So she had this intermittent changing lameness. And then it went on, and she was sort of not eating, but I thought she's a Great Pyrenees, that's what they do, and blah, 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 blah. And then on a Monday night, one day, or Monday midday, she had this huge full body muscle tremor. So she was just spasming. Everything about her was spasming. I thought it was a seizure at first, but she didn't lose consciousness. And then, of course, I grabbed my stethoscope, started to check her out after the fact, and she has a grade 4 heart murmur. So this poor dog had these intermittent clinical signs that I didn't notice, and I'm an RVT. I should notice these things. I should put the clinical picture together. But I didn't know about Addison's at the time very well. And then she had this huge episode of muscle spasms and then a cardiac episode. So then by the time we got down to Friday of that week, it was exam week at school. I brought her in. I teach at the school, of course. Brought her in, and she could barely walk. She could barely lift her head. She was full-blown falling apart. We tried to get a blood pressure on her. She had no registerable blood pressure. She was pale. We couldn't hit a vein to get an IV catheter in, so of course it's like, get her butt over to the Emerge Clinic ASAP. So we put in an IV catheter, and they did supportive therapy, fluids like crazy, and the next step was to fully diagnose it. So my dog Leia was having an Addisonian crisis, which means that everything was so far out of whack in her body. So her electrolytes were so poorly out of whack, so poorly managed, that her body just gave up. Her blood glucose was super low, so nothing was functioning. And of course, she's also a higher stress dog, so when she was stressed out because of whatever reason, if it was her separation anxiety, if it was thunderstorm, whatever it was, then cortisol wasn't being produced to help the body cope with stress. So she fully tried to die. But she made it through, but she definitely tried to die. Okay, so the laboratory signs, we have to run blood work that is looking for Addison's if we want to find Addison's. And what I mean by that is most panels in clinic don't have electrolytes. And our electrolytes are going to tell us a whole lot about this dog if it is Addison's. So what we often see is a decrease in blood glucose because, again, that cortisol stimulates that process through the liver to increase the level of glucose in the blood. So without cortisol, we're not getting that boost of blood glucose when the body needs it. So then the body just quickly eats up the blood glucose that it has. We're seeing a decrease in sodium and an increase in potassium. And those right there, that low sodium-potassium ratio, that is a keystone to Addisonian. definitely, especially in Addisonian crisis. And then in times of crisis, we're going to see a low blood pressure, and it can be significantly low blood pressure, okay? And again, it's that cortisol. It's not telling the body to increase blood pressure during times of stress, so the body physiologically and physically just kind of falls apart. Irregular heart rate, because we have that sodium-potassium exchange, it's affecting the musculature in the heart. And dehydration comes on quickly. A lot of times these guys are PUPD for quite some time. They're losing muscle mass for quite some time, but owners don't often pick up on that, and I'm a perfect example of an owner who didn't pick up on it. So we ran an ACTH stim test to confirm that it is Addisons. So what we would do is take a blood sample, and we would run a resting cortisol level on that blood sample. Leia had 0. She had like -0. She had no cortisol at all. So a cortisol level of less than 0.2 micrograms per deciliter is considered consistent with Addisons. So then we give ACTH, and we would expect in a normal animal that cortisol to increase in its level in the blood, in the serum. So in dogs with Addisons, we don't see an increase at all because they're not able to register that, and it's not affecting their production of cortisol. So that is consistent with Addisons. Likewise, on a stress leukogram, so when we're running the CBC, the doctors are often starting to look for stress leukograms, and they're not seeing that increase in neutrophils and decrease in lymphocytes. So they don't have a stress leukogram because, again, their body is physiologically not reacting properly to that fight or flight response. So for treatment, there are 2 forms of treatment. So essentially, cortisol is the hormone that allows the body to deal with stress, one of the main hormones. And what was I going to say about that? Corticosteroids, so prednisone, is synthetic cortisone. So keep that in mind while we start talking about this. So they do need steroids in general. They need a mineralocorticoid, which is either in the form of an injection, which is percortin, or they need an oral mineralocorticoid. So one of the two. And then a lot of dogs also need prednisone. So they also need a corticosteroid in conjunction with these medications. So the options that are available, like I mentioned, number 1 is injectable. So this is percortin, and it is 2.2 milligrams per kilogram once every 25 days. Leia, we ended up giving her every 28 days, and that seemed to work okay. She used, I think her dose was like 3.8 mils, so essentially she was 1 bottle per month. The bottle was $242 at cost back in like 4 years ago. So that's gone up significantly now. It's about $270 Canadian at cost, which is really challenging for most owners if they have a large breed dog. And Leia, I tried desperately to extend the life of percortin in her body. So I would see as far as it could go before she started to show clinical signs again that she needed more mineralocorticoid. And we got up to 28 days. And at that 28-day mark, she would start to die. So she would start to get lethargic, not eat, start to vomit, and I knew right away, okay, let's get your percortin on board. I can't stretch out this cost anymore. So she was also a dog that had a lot of stressors in her life, so perceived stressors. She was a dog that had major separation anxiety, and it used to be as bad as me going to have a shower. She would lose her marbles and claw the walls and blah, blah, blah. She also had thunderstorm and firework anxiety pretty severely. So needless to say, she always also had to stay on prednisone. And then during times of stress, if we were leaving her overnight or if we knew there would be fireworks, we'd have to increase her prednisone as well. So she was a high maintenance dog, to say the least. The other option is Florinef, I think is the trade name, and it's a mineralocorticoid, and it's 0.02 mg per kg broken into BID treatments. So these are 0.1 milligram tablets. And it just depends on the size of the dog. For some clients, this is really easy for them to administer, really easy for them to administer, maybe 1 or 2 pills twice a day. For us, with a large breed dog, we were looking at like 10 pills twice a day or something crazy like that. So again, it is an option. It's much more cost effective than the Percortin, hands down, especially for a larger breed dog. But then again, they have to give it twice a day, every day, at the same time. So that ties the owner into a schedule. And it's also challenging to give twice a day. Numerous pills if it's a large breed dog. So downfall of Percortin, extremely expensive. Downfall of Florinef, it's a lot of pills and it's twice a day. The other thing I hadn't realized at the time, which again, I just love giving people my knowledge once I've gained it, is that long-term use of steroids. We already talked about how it can create the potential for a diabetic animal, and I already knew about that, but it was a risk versus benefit. But it also can decrease the integrity of the ligaments in the dog's body. So for this, it was within, I think, 6 months of treating the Addisons at high doses of steroids that Leia blew her cruciate ligament. So she blew one cruciate ligament. She had to have a TPLO performed on that leg, and then 6 months later, she blew the other cruciate ligament. So it's kind of like you get past one hurdle, and then there you go. There's another roadblock. So this dog was wonderful. Wonderful, but challenging. So there is treatment for Addisons, but again, like us as RVTs, we have to talk to the clients about it. So they see their dog, oftentimes we see these dogs in crisis, and that's when they get identified as having Addison's disease. So then it's after the crisis, okay, the dog's alive, that's really good news, they're really happy, but now they need to know about this long-term, lifelong treatment, because this dog will never, ever produce cortisol on its own again. So this is a commitment that the owner needs to make, and it is a time commitment, it's a financial commitment, and it's a regular commitment to watching for clinical signs in their dog or cat, but in their dog, to make sure that Addison's isn't coming back and that they're still tolerating the medication really well. And then it's also wise to talk to them, at least have the doctor talk to them about long-term steroid use and its implications with blood glucose regulation and ligaments, because I wish I knew that, but that's okay. So this was our beast of burden. This was Leia, and then this is Piper. Piper's the one that you guys probably hear. She sounds like Darth Vader in the background sometimes, but this is Leia, so I'm just gonna bore you with pictures of my beautiful beast. And that was after her first TPLO surgery, and the hair is only just starting to grow back. She was a good dog. She is again. And then lastly at the cottage, walking on thin ice, as she did. So Leia ended up in the end living, how old was she? She was about 6.5. And of course she ended up getting bone cancer in the end. And that was it. That was our call. But they can live super happy, healthy lives with a whole bunch of these illnesses. We just have to prepare clients for the long term. We need to let them know what they're up against, and then we also need to empower them that they're able to do it and make their lives really great again. So this is a nice little chart for ACTH stimulation test. It talks about when we use the ACTH test and then its results, what they are indicative of, with Addison's disease on the left, and then the association with Cushing's disease on the right.
So tightly, as if I'd float